Hello and good morning, everyone. My name is Jeff. I'm the Director here at Insights. My pleasure to welcome you to today's webinar. Before I continue, I'd like to acknowledge the traditional owners of the land of which we're gathered here today and pay respects to elders past and present. I'd also like to extend that acknowledgement to any Aboriginal and Torres Strait Islander in the room today or joining us across the country in webinar land. I'm here in Meanjin, Brisbane, on the land of the Turrbal and Yuggera people. And I'd also like to especially acknowledge, I guess, the enduring impact of substance use upon the social and emotional well-being of our Aboriginal and Torres Strait Islander community members. Also like to recognise the living experience of people experiencing problems with substance use, mental illness, self-harm and suicide, their families and carers, and that we're here, and that's the reason why we're here doing the work that we do. So today is very exciting because we're here to, I guess, provide some information on a brand new program or an updated kind of programmatic response in Queensland. It's my pleasure to be introducing Margo Watson, who's the Acting Inspector of the Drug and Alcohol Coordination Unit within Queensland Police, and Anjuli Dudley, who's the Principal Policy Officer with the Mental Health, Alcohol and Other Drugs Strategy and Planning Branch within Queensland Health. And today they're going to be talking about the expanded police drug diversion program. So without further ado, by the way, if you have any questions or comments throughout the webinar, please feel free to type them into the chat and we'll be monitoring them. Some of them may be answered through the course of the webinar, but if there's any time at the end, we've got time for questions and answer. So without further ado, I'd like to welcome Margo to the stage.
Thank you, Jeff, for the introduction, and good morning, everybody in the room and online. As an introduction, as Jeff did say, I am Margo Watson and I am the manager of our Drug and Alcohol Coordination Unit at the Queensland Police Service. The easiest way I like to describe DACU and what we do for our organisation is that we are the bridge between law enforcement and health responses when it comes to the National Drug Strategy. And we're very proud of that role. We're a unique unit, and that is why we are so embedded in what we're going to talk about today, which is our expanded police drug diversion program. What Ange and I are going to do today is we're going to talk through a high level about the evidence base, the reason for change and what we have done and why we have done the changes to the program. I'll get into some of the details about what the program looks like, some eligibility and what the model looks like moving past the 3rd of May. And then Ange will come and have a chat about the health responses and what they look like. So let's start with what is police drug diversion. Police drug diversion program in Queensland has been around for over 21 years. It's been a one model that we have had, an approach for that 20 years, which is very limited in what we've been able to do. But it is a harm minimisation approach to the personal use of illicit drugs. And but it's definitely taking the focus of personal use, drug possession and use, and responding to it as a health response rather than a criminal justice response. The absolute intended outcomes of the program, and it has been for the 20 years of the program, is that we're reducing the harms for people who use drugs. And those harms absolutely are about getting the right health response at the time that the person may need it, but also the harms that are associated with the criminal justice system. And absolutely, we cannot do this without partnering with Queensland Health. While the title is a police drug diversion program, it absolutely is, but we cannot do it without the assistance of our colleagues at Queensland Health. So we know that drug diversion works, and this is why we believe we should do more, and why we have been able to convince the government and all our other stakeholders for the moves forward that we are doing. We are very open about this not being a conversation about decriminalisation. This program gives police more options to deal appropriately with personal use, low-level drug possession. It absolutely is shifting the focus on that possession being a health response and not a criminal justice response. So we are just moving it away into the most appropriate stream. As I said, it does give our police officers more options, and you will see that as we talk through the model. It's giving them a bigger toolkit, to be able to respond appropriately in the circumstances. I won't hide behind the fact that this has incredible efficiencies and savings for our service, and for the agencies that support us and for the court system. That goes without saying. But I also want to acknowledge that this has got great benefits for our community. We are shifting this response into more appropriate harm reduction response. And that, for me, if I be honest, is the #1 priority of this program. The reason for change, as I have said, it's been 21 years since we've done any changes into our program. And it was introduced at the time where the National Drug Strategy was released, and it was a priority of that strategy for all Australian jurisdictions to introduce drug diversion models. And other jurisdictions have kept up with contemporary measures and been able to improve and change their programs over time. And this is our opportunity to do that. As I said, it was very, very restrictive, or it is, because we still have that model until the change. It is a one-time opportunity only for a small possession of cannabis and cannabis utensils only. And there are strict eligibility criteria in around it. The person must admit to the offence in an electronically record interview. There are certain caveats for those with previous violent histories are not eligible. So a really, really restrictive eligibility criteria. In 20 years, dare we say, the community expectations have changed. How people use drugs and the way they use drugs has changed. And we need to be able to respond to that, because that's what the community expects. So what is the intent of the legislative change? So as you can imagine, in everything that I have spoken about so far, we wanted to ensure that the intent of the changes that we made to the legislation reflected what we were seeing in the evidence base, what we were seeing from community expectations, and what was best for the person who was using drugs. So the enhanced program puts a focus on a health-based response to minor drug offences, which include a small quantity of any type of dangerous drugs and the non-medical use of some pharmaceuticals, to better address those causes and any of those harm reduction strategies that we may need. And this certainly aligns us with other jurisdictions in Australia. I feel we're also almost going one step ahead of our other jurisdictions, because they are all now looking to us to see what we have done in this space. I will also say that Queensland is one of the only jurisdictions in Australia that has a legislated model. And what does that mean? It actually mandates the program, and it requires the police officer to offer a program to a person if they are eligible. Other jurisdictions, it's based in a policy state, so there is a lot of officer discretion within those models. And this has been the case since the introduction of the current program, and we wanted to continue that mandated process. So I've talked a little bit about the reason why and the legislative changes, and they are confusing, as legislation always is, and it's our job in implementation to make that very easy for the community to understand, but for all those stakeholders involved in this process, and certainly our police. If you've heard me present before on our police drug diversion program, you will hear that this is a significant culture change for our members. Our members have been trained and taught only to respond to drugs in one way, and we are now changing that for them. So it is a journey for them as well. And that is our job at DACU, to bring them along on that journey. But when we talk about the legislation and what it means practically in a model, I always talk about three things. 3 significant changes that we made to enable this new expanded police drug diversion program. The first thing that we did was we updated the definition of what a minor drugs offence is. And that is all embedded in our Police Powers and Responsibilities Acts. And what we did is we changed the definition from 50 grams of cannabis and any utensils to include all dangerous drugs and also the non-medical use of prescription pharmaceuticals, so the Schedule 4 and Schedule 8 medicines that are being used in a non-medical way, and all the things and utensils associated with those drug use. So all the paraphernalia that you may use to consume those drugs. That's a significant increase of what is eligible now for drug diversion. So it absolutely increases. And if you're sitting there and thinking, I wonder if that includes heroin, yes, it does. I wonder if it includes fentanyl, yes, it does. I wonder if it includes methamphetamines, yes, it does. And not only does it include those drugs, our policy has outlined that poly use is to be considered in this model as well. So it's not limited to the person has one drug and that is it. If a person is able to articulate to a police officer during the investigations, a person may be eligible for drug diversion if they are able to explain their personal use of a variety of drugs, because that's how drug use has changed over time. We no longer have a person using one drug. So it was really important to make sure that that definition was contemporary. The second thing that we did was we removed the barriers to participation in the eligibility criteria. And this came about as a number of recommendations from inquiries that the government had held over time. And we recognised the vulnerable cohorts and we looked to our eligibility criteria. As we know, making admissions in an electronically recorded interview is very, very confronting, and a number of our population do not do that. So that automatically in the current model strikes you out of being eligible. So what we've done is we've removed that particular eligibility criteria. Now, there is a little bit of misunderstanding with what that means. A lot of people now assume that you don't have to make admissions, and you're right, you don't have to. You do have the right to silence. That is your legal right. However, a police officer still does need to establish what we call a prima facie case. So on the face value, we have the evidence to present if we need to. So a police officer must reasonably believe that the interaction with the person and the possession of those drugs is for personal use, and that we would be able to establish a prima facie case and send it to court if we had to. So here's where this toolkit comes into place. So the toolkit now says, your options are you do not have to send that person to court. You can offer a drug diversion. So to my members, I say this: if you're going to issue them a notice to appear, then you can issue them a drug diversion. If you've got enough evidence to send it to court, you've got enough evidence to send it to a police drug diversion program. One of the other barriers that we removed was the eligibility criteria that we currently have that limits a person who has a previous conviction for a serious violent offence. Again, let's talk about the contemporary environment that we live in now. 21 years ago, that was put in. We did a lot of research to understand why that was there, and in all the government documents, we can see it was put there for service provider safety. So it was put there to protect a service provider in a face-to-face environment, that you wouldn't have a person that had potential violent history. We all know that TeleD is available now, and there are lots of other remote options. So we have removed that as an eligibility criteria in our legislation, because that is very, very restrictive. but it doesn't remove that risk assessment and how we manage those people who may have a violent history, who may be known to carry knives and so forth. We manage that in policy so that those people won't be eligible to have a face-to-face appointment. They will still be able to access the program, but via remote means. And that certainly is the role of the police to assess that risk in consultation with the diversion coordination service when booking the appointment. So that's the second thing we did. So already you can see how we're already expanding this program to be far more inclusive and really responsive to the way our community expects police and health responses to drug use. The third thing we did was we introduced a 3-tiered health response. Now, our 3-tiered health response looks like this. On the first interaction with police, if you are eligible and you have not previously had a drug diversion program in the current program, you can be offered a drug diversion warning. And that, simply as the name suggests, is a warning. The person will be offered, and they do have to accept. If they don't accept, unfortunately, we have no other choice but to send them to court. However, if a person accepts, we do issue them with a drug diversion notice. And that notice has the details of our interaction with them and some options down the bottom with some QR codes to access some health treatment services if they like. This particular step is, there is no compulsory follow-up by police. There is not a mandated completion of this stage. It is simply, as the name suggests, a warning. The second and third tiers are our drug diversion assessment programs. And the first one, obviously, in legislation is the initial drug diversion assessment program, and the second is the subsequent drug diversion assessment program. However, these for this room and our audience are our health responses. This is the health response to the personal use of minor drug offences. These programs, I say to our members, are what we know and what exists now. How we get our client to you, to be your client, we do through our diversion coordination service. We will continue to make those booking arrangements. But this time, another little barrier that we've improved, I believe, is that the person has 90 days to complete the program. So you may all be aware that currently the program says that you must attend at this time, at this date, at this location. If they don't, it comes back to the police for consideration of a reschedule. However, what we have done is we have allowed that to be completed within 90 days. So the Diversion Coordination Service will assist us in rescheduling as many times as we need to have that person complete that program within the 90 days. Again, this is about getting the person the access to the health service that they require. Once a person does move through those tiers, the fourth interaction with police, we have reached the end of our toolkit, and it does mean that that person goes to court. So we will issue them with a notice to appear. Can I say that adults, if they are eligible, must be offered this program by police? However, if it is a child, a police officer may. Now, this, again, caused a lot of controversy at the introduction stage of this legislation, but we did this on purpose because Section 11 of the Youth Justice Act mandates how we respond to a child. If we were to put must in there for a child, it would take away the opportunity for that child to have no further action taken, to be cautioned, to have a conference instead. Or in fact, maybe go to court. So what we did was we updated Section 11 of the Youth Justice Act to include the drug diversion program. So that is the model that the police officer consider. It is an option within the Youth Justice Act. So that is the reason for may. I did have a thought and it's gone. So a child and an adult. And I also want to talk about the intersex. So obviously at that fourth tier, we send the person to court. As you would be aware, the courts do have a couple of different programs as well. So they have the court, illicit court drug diversion program, and they also have DAR programs. And a person is still eligible for those programs through the court system as well. So you can see that we've increased our opportunities across both the police responses and the court responses to be able to include the best outcome for that person. I also quickly want to highlight with this model, what does it look like intersecting with the current model? So if a person has in the current cannabis program, we will refer to it now as the cannabis program. If they have previously received a drug diversion, then they will, in this model, move to the next tier. So that cannabis program is considered the initial drug diversion assessment program. So they will still have another opportunity in this new model to move to the subsequent program. It is not retrospective. However, it still does allow that opportunity for another drug diversion assessment program. It was really important for me to stand here today and talk to you about how a police officer is able to assess the situation, have a toolkit available to them, and be able to then to refer them to the health response. It's at this stage, once we have the appointment and we're off to the health response, that Anjuli will come up and have a chat about that.
Thank you very much, Margo. So I'm Anjuli Dudley, and I'm from the Mental Health, Alcohol and Other Drugs Strategy and Planning branch, and have been working with Margo and her team for several months now to support the implementation of this expanded program. So I'm very pleased to be here today and talk to you about our health response. So I'm just going to start by giving you a quick overview of our current health response to the current police drug diversion program. So as Margo said, it's been around for a long time and was part of Queensland's implementation of the National Illicit Drug Diversion Initiative. It commenced in 2001 for minor cannabis possession offences, and Queensland Health's role in that is to provide the health response, coordinate appointments, and provide some program reporting, which we do through our diversion coordination service. Since it commenced, we've had over 160,000 people referred through the police to the health response, which is really fantastic. I also wanted to mention that since 2003, so also over 20 years, we've delivered the court diversion program, which is for all illicit drugs. So we have a really strong history of engaging with clients across multiple substance types. So the health response that we deliver is an assessment, AOD assessment, motivational interview, information and education, harm reduction strategies, some relapse prevention, and referral into the voluntary AOD treatment system if the person is indicated and wants that referral. In the initial days of the program, the health response was much more focused on just information and education. But as you know, things have developed, it's sort of more of a brief intervention now. So it's delivered by a mix of HHS and NGO providers, and can be delivered by telephone or in person. So depending on the person and the way that it's being delivered, it can sort of range from between a 45-minute to 2-hour session. So our hospital and health services and state-funded non-government providers deliver the program in person. And then since 2019, and following a very successful trial, we've established TeleD, which is delivered through ADIS, 24/7 alcohol and other drug support, and they provide the telephone health response. And as I said, our diversion coordination service really helps to coordinate all the schedules and appointments across the health service providers and provide some program reporting. So when the changes to the police drug diversion model were being discussed, we thought it was a great opportunity to re-engage with our health service providers and, you know, identify some opportunities to improve the program and our health response, and also consider whether or not we're going to see the same sorts of people through the program and whether the health response needed to be adapted at all. So we met with them in March last year, and it was really helpful in helping us to develop some foundations for the health response under this expanded police drug diversion model. So those foundations are that it should be contemporary and evidence informed and delivered by a specialist alcohol and other drug services, that it needs to be a proportionate response for a minor drug offence. So this is personal use, it's a small amount, so we don't want to overcook it. And it's also people coming in voluntarily to participate in the program. We also want to make sure that it is tailored to the person's current or cumulative situation. So they may have been diverted through court models before. And we know that we already get a variety of people that come through our police drug diversion program. So some people don't use drugs often, and some people are using them frequently. Some people are experiencing dependence and some are not. Some are ready to change and others are not. So we see a wide variety of ages and all different walks of life. So we really want to make sure that when we're delivering the health response, it's tailored to that person and meeting them where they're at the time. We also want to make sure that the response that we're delivering is effective and timely and can be flexible. So we know that if people are able to get into a health response within 14 days of their referral, they're much more likely to engage in the health response and get some benefit out of coming to the health response, but also they're more likely to complete the program and then not have to go back and deal with police or courts. And one of the other ways that we're trying to make sure that the program is accessible and able to be flexible is by offering it in multiple modalities. So that's exciting. The other thing that we're doing is just making sure that our approach is streamlined. So we want to help improve the coordination of the program, and that's for police, health, and people that are diverted. So in the expanded police drug diversion program, we'll continue to deliver a single session as a health response, and it will be tailored to the person. And this health response will be the same approach at tier 2 and tier 3. So we might get someone through tier 3 that's just had a tier 2 2 weeks ago, or it could be years between referrals. So it's really important to never assume and to always meet them where they're at and tailor the response to them. So the health response will include an AOD assessment and then any combination of information and education, harm reduction strategies, and other counselling approaches. So it can be flexible to provide what the person, what they want and need, and adapt it to that. I guess with that as well, we're sort of anticipating that once you do the AOD assessment, it could sort of range anywhere between 60 to 90 minutes, including some paperwork time. So it will depend on the person and where they're at. And of course, we want to make sure that for people who want to access further treatment and support, they can be referred into the AOD treatment system. But for the purpose of police drug diversion program, once they've completed that single session, that's it. So the modes of delivery through our HHSs and state-funded non-government providers, they'll be delivering the program in person individually, and there'll always be the option for the person to bring along a support person with them if they would like. The HHSs and NGOs will also be able to deliver the program by video conference now. So we're really hoping that that will kind of help to, get the benefits of in-person service delivery and telephone delivery by offering this video conference mode, which I think a lot more people are familiar with and comfortable with using now compared to a few years ago. And that will be delivered through Microsoft Teams. And then in limited circumstances, there may be the option to complete it in a group. TeleD will continue to offer the police drug diversion by telephone. So I guess in summary, as you can see, the health response is not significantly different to what we're doing already, but I guess we will want to continue to focus on a tailored response that's person-centered, and being able to deliver by video conference, we're hoping will improve options for people and health service providers. The program will still be coordinated by our diversion coordination service. They coordinate and manage the appointment schedules across multiple services, and with police and health service providers. So they are the first point of call when police have the person and they've accepted the diversion referral. The police contact the diversion coordination service and arrange that first appointment. So they'll continue to do that. The diversion coordination service will also continue their important role in program reporting. But I guess one of the new things for the diversion coordination service, which is really exciting, and one of the ways that we are streamlining our approach, is to allow people that have been referred by police to contact the diversion coordination service directly if they wish to reschedule their appointment. So at the moment, that person would have to go back to the police officer, and it's a hassle for the person, it's a hassle for police, and it's annoying for our health services too, that just want to be able to be responsive to the person. So we're very excited about that change. The diversion coordination service will also be responsible for supporting the video conference appointments. So they'll be sending the video conference links to the service provider and the person that has been referred. And then they'll be able to provide some technical support as well if there's any issues. And just a flag that there is no change for the court diversion program in terms of rescheduling. So if it's a court diversion referral, that person still needs to go back through the Department of Justice and Attorney General if they want to reschedule their appointment. So in preparation, we have been working with Insight to update the online training that's available. And that will be available soon. That training will include some screening tools, resources, job aids, links to other optional training that you might want to engage in. It'll have this webinar recording on it. And it will also have an operational manual, which we are updating as well. So we're very excited. At the moment, the training really focuses on some of the legislative aspects and eligibility, which is more for police. So we're really trying to focus our training now on the health response. So thank you very much to Insight for helping us with that. And I'll get to Margo again.
I think I will be cheeky and just talk about the police training component as well, to give some comfort on the extent of the training that we're doing with our members. I will say that the culture piece and the conversation around drug diversion has been more than 12 months, and that's a really important part of our training for our police. It's the culture piece. However, as you can imagine, we also do have some compulsory training products for our police to talk them through the legislation and what the requirements are and how they can data entry and create all those things. But I was really, really, really adamant that this time we were doing training and not just telling a person what to do, but providing the evidence base and the reasons why. Because I think if you understand why we're doing something, you do it well. And we also, as part of the parliamentary inquiry, and again, I was an advocate for this, one of the recommendations in the training is that we included a stigma piece. And I'm very, very proud to say that we have just finalised in the last day the stigma piece that is being attached to the compulsory online learning product for our police. So that's a really important part. The slide that I'm going to talk to you about is evaluation. And again, another piece that the team at DACU and Health were really strongly advocating for. And I think it's fair to say that we didn't want another 20 years to pass without looking at a model. So this evaluation is really important for us to be able to have an insight into the program as it's been implemented. It's a 2-year evaluation piece. However, we do have a 12-month insight report for it as well. We are undertaking the procurement process for that. Is an independent evaluation, and the vendor will hopefully be on board at the time of go live. It's important that when that vendor does come on board, that the framework for their evaluation is informed by all of those that have contact with the program. So that includes the service providers, it includes those people who will be participating in the program, as well as police. So it's not just focused on the police aspect of the evaluation. Implementation has been significant. We have at our organisation stood up a project team to do the implementation activities for this. And I would like to absolutely give a shout out to the team. They have done an incredible job to get us to where we are, working with Ange and Julie and their team to be able to deliver this expanded police drug diversion program, a significant change in the way that Queensland responds to personal minor drug use. So it's been absolutely a team effort, and I'm really looking forward to the 3rd of May, which is go live. As I've said, the together we can. I know my team online will be smiling when they hear me say that, because I do believe that. Together we can. We will continue to collaborate and lead this program. I can stand here and tell you that DACU at project implementation does not step away from this. So the police drug diversion program is a capability that we own for the life of the program. So as business as usual, this will continue to be a priority for DACU. So the aftercare model that our team will continue to have with police, community, health and clients will continue. And that's really important for the program as well. It's not one of those ones we implemented and walked away. So I thank you very much for your time today. And I have no doubt I can see the activity happening in front of me with all the questions online. So let's see who gets the first question, Ange.
Thank you very much, Margo, and thank you, Margo and Ange, for that very informative and detailed presentation. There are a couple of questions, and maybe there are from the room as well. I'll ask you, Margo, first, because you're on the stage.
Sure.
And I think it's covered, but just to clarify,
sure.
There was a question that, is the person still eligible for diversion if the possession is not the only offence? Say there might be a traffic or another kind of theft or criminal offence associated. Are they split out?
Yeah, absolutely. Great question. And part of the eligibility criteria, we do stipulate that if the minor drug offence is committed with another indictable offence, then a person may not be eligible. So if you're talking about a traffic intercept, those simple offences, then absolutely a diversion can still be considered. However, if, say, for example, that indictable offence, so an indictable offence is a more serious offence on our statute books, a break and enter where the person was breaking in to get money to buy drugs, or shall we say that there was a supply offence associated, then that person would not be eligible.
Thank you. There was a question about data and evaluation. So to that person, I think it's largely being covered. But just to clarify, and I think you mentioned this, there was a question about whether a person can self-refer to diversion if it's been referred to court. And the answer is no. Is that correct?
Yeah, there's no option for self-refer. However, once you're in the system, there's toolkits for us to be able to do. So obviously the police, we can use our toolkit for the drug diversion. And in court, obviously there's a model for a person to access those programs. Hope that answers it.
I think, yes, that does. We may not know the answer to this, but there was one other question. Is there any maybe estimates around the impact in terms of the number of people being referred into the program with the expanded kind of criteria?
Yeah, Ange talked about in her presentation that over the lifetime of our cannabis program, we've referred 160,000 people into the program. And that's incredible. And we know the majority of those people do not come into contact with the criminal justice system again, and they complete their program. So we really, really good statistics. So we've always had, and as I have said, we own drug diversion as a capability at DACU. So we've always been monitoring and have access to data. And one of the things we absolutely had to do for the implementation or even just the policy perspectives of this was do some data modeling on what it looks like. And we have done that over the data that we hold in our computer records. And we have, gee, it's been a while since I've talked about these numbers. We know that in the first year that we expect to see 25,000 people access the program. That's significant numbers. In the first 12 months, 25,000. Now, 17,000 of those we estimate are going to be at the warning stage. So already that bulk of people that we see will have access to that. Tier 2 and 3 combined, so the drug diversion assessment programs that get referred into the health responses, we expect to see them at around our current numbers, which is between 9 and 10,000. So really great numbers. And then as you can appreciate, we modelled again then on year 2 and then year 3 of the program. I will be honest, those numbers escape me at the moment. However, as you can expect, we saw slight decreases in the warnings over time. And then obviously the bulk of the people then starting to, you know, sort of move through that program. But really, really great numbers.
Excellent. But you could answer that on the spot. Well done.
Thank you.
There was a question, and maybe you kind of covered it, but just to clarify for one of our attendees, if someone has already attended a session prior to when the new model starts, will that count towards the number of chances, or does it get wiped clean?
And it does. It does. So if you have had a current cannabis program diversion, then you come into this new model as having completed the initial drug diversion assessment program. So you would then automatically just move into our subsequent one. So you get a second opportunity. Yep.
I might let you off the hook now for a little bit because you've done so well, and maybe just ask a few questions to you now, Ange. In regards to more of the drug diversion assessment program. There was a question, like, is there a difference between the stage 2 and stage 3, the subsequent programs, in terms of what's offered? Is it a step up, or is it largely the same intervention?
I think that will really depend on the person as they come into the health service. So you can't assume that because someone's been diverted again that their drug use has changed or escalated, but it may also have. So I think that's why it's really important to do your assessment and then make sure that your response is tailored to where they're at in their personal situation. You know, they may have had changes in their substance use or changes in their readiness to change. So it may be different. It will just depend on the person at the time.
Yeah, so effectively it's not a standardized response, it's a very tailored individual response to that person.
That's right.
Yes, excellent. There was a question as well, does the person have a choice between, say, accessing Tele-D or a face-to-face, or when they contact the DCS?
They may do. It depends on whether there's any risks that are flagged. If there is, then they may only have the option to do it by video conference or telephone. But it also depends on what services are nearby and when the next appointment is. So we will try and get people into appointments as soon as possible and with the service that's closest to, you know, where they're living or working, whatever is convenient for them. But it will differ according to where they are.
Is there a waiting list for Tele-D?
I think it's like 2 or 3 days. So no, not really.
Not really. And I think I can answer this question, but correct me if I'm wrong. Yes, the Tele-D service is purely run by ADIS. Other HHSs, like NGO providers, are not necessarily going to be providing that. However, the Teams-based video conferencing potentially is on a case-by-case basis.
Yes, that's right. So Police Drug Diversion Program is delivered by telephone through Tele-D, and then the NGOs will be able to deliver it in personal video.
I think there's probably some questions in there that I don't think are able to be answered in this particular webinar. We'll respond. Okay, there is a question here. In the first year response, what resources will the QR codes link to in the warning?
I believe they link to ADIS, and people will be able to find services or information on the ADIS website.
I think if someone has provided a warning and then has a possession charge 13 months later, would they then start the initial program?
Margo, you want to answer?
Oh, thanks. Roving Mark. That's exciting. So the question was if they've had a drug warning notice and then 13 months later, they have a possession offence that a police officer, if it is an eligible minor drugs offence and they meet all the eligibility criteria, then yes, a police officer can then offer them the next year. So it is not time limited in between each of the tiers. So if it is 13 months, if it's 2 years, 3 years later, the person just moves through the program. So absolutely, if they are eligible.
Stay here. I've got one more quick question for you. What if the person is already in a probation or parole order? Does that affect their eligibility?
From our perspective as a police officer, at the time of our interaction with the person, we will just deal with the person as they present to us. However, it is always in the best interest of the person to relay to their probation and parole person the interaction that they've had with police and the result of it.
Do we have any questions from the room? No. There's a couple other questions, but we might try and answer them directly because I think they're outside the scope of this particular presentation. I think you've covered one about a sunset clause, like it happens 40 years later. It's still recorded, and it's part of that subsequent kind of process. There was a question around the volumes, like has there been a change to the limits, like the 50 grams or the 1 gram of kind of powders in terms of the...
Yeah, that's a really good question. We, in our terminology, refer to that as the prescribed quantities. So our Act, our Police Powers and Responsibilities Act, refers to a regulation, and that regulation is being drafted at the moment. But yes, as we have previously discussed, it is around that the 1 gram, 50 grams of cannabis, and then the minute quantities for certain drugs. Very, very similar to what's already been occurring in the court system for many, 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 many years.
I think that's it. You've done incredibly well to answer so many questions off the cuff and provide responses to all of our webinar participants. So if we could please join me in thanking Margo and Ange. Obviously a huge amount of work between various departments and with big system impacts, so we really appreciate the amount of effort that's gone in, and lots of people from interstate very interested attending today. So great to know that other states and territories are watching. Thank you for joining us here today. We're having a little break for Easter now, the presentation after Easter happens to be myself and James Hoey talking about have you got spare 20 minutes, kind of new approaches to AOD learning and just-in-time resources for the workforce. So thank you everyone for joining us today. Hope you have a great week and a great Easter break, and we'll see you afterwards. Thanks and goodbye.